5 medical tests that seniors over 70 should avoid because risks outweigh benefits. Number 3 involves brain imaging that causes more harm than good. After age 70, the approach to medical testing fundamentally changes. Tests that were appropriate and beneficial in your 50s and 60s become questionable, potentially harmful, or completely unnecessary once you reach 70 and beyond. This isn't because healthcare becomes less important as you age. It's because the risk-benefit calculation shifts dramatically. Tests that might detect problems early in younger adults often cause more harm than good in people over 70 through complications from the procedures themselves, false positive results leading to invasive follow-up testing, overdiagnosis of conditions that would never cause symptoms in your remaining lifetime, and treatments that are riskier than the conditions they're meant to address. According to research from JAMA Internal Medicine examining medical testing in older adults, overuse of screening tests in people over 75 leads to cascades of additional testing, procedures, and treatments that reduce quality of life, increase healthcare costs, and paradoxically worsen health outcomes compared to not screening at all. Multiple major medical organizations, including the American Geriatrics Society, the American College of Physicians, and the U.S. Preventive Services Task Force, have issued specific recommendations against certain tests in older adults, yet many doctors continue ordering them reflexively without considering whether they truly benefit the individual patient. What makes inappropriate testing particularly problematic in people over 70 is that your body handles procedures differently than younger adults. Kidney function naturally declines with age, making contrast dyes used in imaging more likely to cause kidney damage. Blood vessels become more fragile and prone to complications from catheter-based procedures. Cognitive function may be more vulnerable to anesthesia and sedation. Recovery from complications takes longer. The risks of testing often exceed any potential benefits from finding problems. In this video, we'll examine 5 medical tests that seniors over 70 should question carefully or avoid entirely, with particular focus on brain and vascular tests that are frequently overused. Number 3 involves brain imaging that's routinely ordered for minor symptoms but leads to dangerous cascades of unnecessary interventions. Number 1 is a vascular screening test aggressively marketed to seniors that causes far more harm than benefit. These aren't tests that should never be done. They're tests where the routine screening approach used in younger people becomes inappropriate after 70. Before we begin, understand this information doesn't mean avoiding all medical care. It means being a smart, informed healthcare consumer who questions whether each test truly benefits you individually. Now let's examine the 5 tests you should think twice about after 70. Test number 5. Routine screening carotid artery ultrasounds in people without symptoms. Starting with a vascular test that's heavily marketed to seniors, screening carotid artery ultrasound to detect blockages in neck arteries is frequently offered but rarely beneficial after 70. Here's why this test is problematic. Carotid ultrasound uses sound waves to visualize the carotid arteries in your neck and measure stenosis or narrowing. Companies offering health screenings at community centers, churches, and senior centers promote these tests, claiming they prevent strokes by detecting dangerous blockages before symptoms occur. The reality is far different. Research from the U.S. Preventive Services Task Force examining carotid artery screening found that in asymptomatic people, screening causes more harm than benefit at any age, but particularly after 70. Here's why. Carotid stenosis severe enough to require intervention is relatively rare, affecting only 0.5 to 1% of asymptomatic people over 70. The vast majority of people screened have normal arteries or mild narrowing that doesn't require treatment. However, ultrasound has a false positive rate of 5 to 10%, meaning it incorrectly suggests severe stenosis in people who don't actually have it. These false positives lead to additional testing with CT angiography or conventional angiography, procedures that use radiation and contrast dye, carrying risks of kidney damage, allergic reactions, and stroke from catheter manipulation. Some people undergo unnecessary carotid endarterectomy surgery or carotid stenting based on imaging that overestimated stenosis severity. Even when true severe stenosis is found in asymptomatic people, treatment doesn't clearly improve outcomes. Studies comparing surgery versus medical management with aspirin, statins, and blood pressure control for asymptomatic carotid stenosis found that surgery prevented approximately 1 stroke per 100 procedures over 5 years. However, the surgery itself caused stroke or death in approximately 2 to 3% of patients during the perioperative period. The risks of surgery often exceeded the benefits, particularly in people over 75. What makes carotid screening particularly problematic after 70 is that the surgery becomes riskier as age increases. Perioperative stroke and death rates in people over 75 undergoing carotid endarterectomy are 2 to 3 times higher than in younger patients. Additionally, life expectancy considerations matter. If you have other serious health conditions limiting life expectancy to 5 years or less, preventing a stroke that might occur in 10 years provides no benefit. The characteristics that make carotid screening potentially harmful than beneficial include being completely asymptomatic without any history of transient ischemic attacks or strokes, being over 75 years old when surgical risks increase substantially, having other serious medical conditions, including heart failure, severe lung disease, or dementia, and having limited life expectancy from other conditions. What you should do instead of routine screening is focus on proven stroke prevention strategies that benefit everyone. Control blood pressure, keeping it below 130/80 mmHg. Take statin medications if you have cardiovascular disease or high cholesterol. Use aspirin or other antiplatelet medications if appropriate for your cardiovascular risk. Control diabetes if present. Stop smoking. Exercise regularly, eat a Mediterranean-style diet. These interventions reduce stroke risk far more effectively than screening for asymptomatic carotid stenosis. If you do have symptoms potentially related to carotid disease, including transient vision loss in one eye called amaurosis fugax, temporary weakness or numbness on one side of the body, or transient speech difficulty, then carotid imaging is absolutely appropriate and potentially life-saving. The key is that symptoms change the risk-benefit calculation dramatically. Testing symptomatic people makes sense. Screening asymptomatic seniors does not. Test number 4. Screening CT angiography or cardiac calcium scoring in people over 75. Moving to cardiac imaging tests, coronary CT angiography and cardiac calcium scoring are increasingly marketed for heart disease screening, but provide questionable benefit after 75. Here's the problem. These tests use CT scans to visualize coronary arteries and detect atherosclerosis. Cardiac calcium scoring measures calcium deposits in coronary arteries as a marker of plaque burden. CT angiography creates detailed images of coronary arteries showing blockages. In younger adults with intermediate cardiovascular risk, these tests can sometimes help guide treatment decisions. After 75, their utility becomes questionable for several reasons. First, coronary artery disease is nearly universal in people over 75. Studies using CT angiography in asymptomatic older adults found that over 90% have some coronary atherosclerosis, and over 50% have coronary stenosis exceeding 50% in at least one vessel. Finding coronary disease in people over 75 is not surprising or particularly informative because it's so prevalent. Second, the radiation exposure from these scans is substantial. Cardiac CT angiography delivers 5 to 15 millisieverts of radiation, equivalent to 150 to 450 chest X-rays. While radiation risk is lower in older adults who won't live long enough to develop radiation-induced cancers, the radiation still causes DNA damage and may accelerate other aging processes. Third, false positive results are common, leading to additional invasive testing. CT angiography frequently overestimates stenosis severity or detects lesions of uncertain significance. This leads to invasive coronary angiography, where catheters are threaded through arteries to the heart. This procedure carries risks of heart attack, stroke, kidney damage from contrast dye, bleeding, and arterial injury. The risks increase with age. Research from the Journal of the American College of Cardiology examined outcomes in people over 75 who underwent cardiac CT screening. Studies found that the testing led to increased downstream procedures, including stress tests, coronary angiography, and revascularization with stenting or bypass surgery, but did not reduce heart attacks or mortality compared to standard care without screening. The testing created a cascade of interventions without improving outcomes. What makes cardiac imaging screening particularly problematic after 75 is that even when significant coronary disease is found, aggressive intervention with revascularization doesn't clearly benefit asymptomatic older adults. Multiple studies have shown that in stable coronary disease without symptoms, optimal medical therapy with aspirin, statins, blood pressure medications, and lifestyle modifications works as well as or better than stenting or bypass surgery for preventing heart attacks and extending life. What you should do instead is focus on proven cardiovascular risk reduction. Take prescribed medications consistently, including statins if appropriate, aspirin or antiplatelet drugs, blood pressure medications, and diabetes medications. Exercise regularly, doing activities you enjoy. Eat a heart-healthy diet, emphasizing vegetables, fruits, whole grains, fish, and healthy fats. Maintain healthy weight. Manage stress. Stop smoking if you smoke. These interventions reduce cardiovascular events far more effectively than screening imaging. If you have symptoms, including chest pain, pressure, or discomfort with exertion, shortness of breath, or other concerning cardiac symptoms, then cardiac testing is absolutely appropriate. Testing symptomatic people guides treatment. Screening asymptomatic seniors creates more problems than it solves. Test number 3. Routine brain MRI scans for minor memory complaints or headaches. This is the brain imaging test that's routinely ordered but causes cascades of harm. Brain MRI scans are increasingly ordered for minor symptoms, including occasional forgetfulness, mild confusion, or headaches in people over 70. Here's why this commonly becomes problematic. MRI creates detailed images of brain structures using powerful magnets. The test itself is generally safe without radiation, but the problem isn't the MRI itself, it's what happens after. In people over 70, brain MRI scans almost always find abnormalities. Studies examining brain MRI findings in cognitively normal older adults found that 90% to 95% of people over 70 have white matter hyperintensities, areas of increased signal on MRI indicating small vessel disease. Over 30% have old silent strokes called lacunar infarcts that never cause symptoms. Many have brain atrophy that appears more advanced than expected for age. Some have small aneurysms, benign cysts, or other incidental findings of uncertain significance. The critical problem is that these extremely common age-related findings often lead to unnecessary worry, additional testing, and sometimes harmful interventions. White matter hyperintensities found on MRI lead to additional vascular imaging, including CT angiography or conventional angiography of brain blood vessels, looking for stenosis or abnormalities. Small aneurysms under 5 millimeters that have extremely low rupture risk and should simply be monitored lead to referrals to neurosurgeons who sometimes recommend invasive treatment. Old lacunar strokes lead to aggressive antiplatelet or anticoagulation therapy that increases bleeding risk without clear benefit. Research from JAMA Neurology examined outcomes of brain MRI screening in older adults with minor cognitive complaints. Studies found that finding incidental abnormalities on MRI did not improve cognitive outcomes, did not prevent dementia, and did not reduce stroke risk compared to not scanning. However, the scans led to substantial increases in additional testing, specialist referrals, unnecessary treatments, anxiety, and healthcare costs. What makes routine brain MRI particularly problematic for minor symptoms is that the findings rarely change management appropriately. If you have mild occasional forgetfulness, which is normal aging, finding white matter changes on MRI doesn't help because there's no specific treatment for white matter disease beyond general vascular risk factor management you should be doing anyway. If you have headaches that are clinically consistent with tension headaches or migraines without any concerning red flag features, finding age-related brain changes doesn't change treatment. The specific situations where brain MRI after 70 causes more harm than benefit include ordering scans for mild memory complaints without functional impairment, normal aging-related forgetfulness where the person can still manage finances, medications, and daily activities independently, chronic stable headaches that have been present for years without any change in pattern, dizziness or imbalance without any focal neurological symptoms, and vague, nonspecific symptoms like mild confusion that comes and goes. What you should do instead is have thorough clinical evaluation first. If you have memory concerns, formal cognitive testing with neuropsychological evaluation can determine whether impairment is present and how severe it is without imaging. If testing shows significant impairment consistent with dementia, then brain imaging may be appropriate to look for treatable causes like normal pressure hydrocephalus, subdural hematoma, or brain tumor. But imaging everyone with mild memory complaints leads to more harm than benefit. Red flag symptoms that do warrant prompt brain imaging include sudden severe headache described as the worst headache of your life, progressive worsening headaches over days to weeks, headaches associated with fever, focal neurological symptoms including weakness, numbness, vision changes, or speech difficulty, significant cognitive decline over weeks to months where family members notice substantial functional impairment, new onset confusion that persists, and falls with head trauma followed by worsening symptoms. Test number 2. Screening cerebral angiography or brain vascular imaging in people without symptoms. Screening for brain aneurysms using CT angiography, MR angiography, or conventional catheter angiography in asymptomatic people over 70 is rarely beneficial and potentially harmful. Here's why. Brain aneurysms, balloon-like bulges in brain blood vessels, are found in approximately 2 to 3% of the general population. Most aneurysms never rupture. Small aneurysms, under 5 to 7 millimeters, have extremely low rupture rates, less than 0.5% per year. The problem is that screening asymptomatic people finds many small aneurysms that would never cause problems. Studies following unruptured aneurysms found that small aneurysms in people over 70 have even lower rupture rates than in younger people. However, treatment of unruptured aneurysms through surgical clipping or endovascular coiling carries significant risks in older adults, including stroke occurring in 5 to 10% of procedures, cognitive decline after surgery, complications from anesthesia, and death in 1 to 2% of cases. Research from stroke examined outcomes of screening versus not screening for brain aneurysms. Studies found that screening and treating small aneurysms in people over 70 led to more strokes and deaths from treatment complications than would have occurred from aneurysm ruptures if left alone. The screening caused net harm. What you should do is avoid screening for brain aneurysms unless you have multiple first-degree relatives who had aneurysmal subarachnoid hemorrhage, certain genetic conditions like polycystic kidney disease associated with high aneurysm risk, or symptoms potentially related to aneurysm, including sudden severe headaches or vision changes. Test number 1. Screening ankle-brachial index and peripheral vascular imaging in asymptomatic people. The number 1 test to avoid is routine screening for peripheral artery disease using ankle-brachial index or vascular ultrasound in people without leg symptoms. Companies aggressively market these screenings to seniors, claiming they prevent amputations and heart attacks. The reality is that screening asymptomatic people causes harm. Ankle-brachial index compares blood pressure in ankles to arms. Values below 0.9 suggest peripheral artery disease. However, abnormal ABI in asymptomatic people doesn't change management. The treatment is exactly what everyone over 70 should be doing anyway, including taking statins, controlling blood pressure, exercising, and stopping smoking. Finding abnormal ABI doesn't add information that changes care. Moreover, abnormal ABI leads to additional vascular imaging and sometimes unnecessary interventions. Some people undergo angioplasty and stenting of leg arteries despite having no symptoms. These procedures carry risks of bleeding, arterial injury, kidney damage from contrast, and don't improve outcomes in asymptomatic people. Research from Circulation found that screening for peripheral artery disease in asymptomatic older adults led to increased testing and procedures without reducing cardiovascular events, amputations, or mortality. The screening caused cascade effects without benefit. What you should do is focus on symptoms. If you have leg pain with walking that's relieved by rest, called claudication, then ABI and vascular imaging are appropriate. But screening without symptoms causes harm. These 5 tests are commonly overused in seniors over 70. Understanding when tests help versus harm empowers you to make informed decisions. Which test surprised you most? Have you been offered unnecessary testing? Share in comments. If this helps seniors avoid harmful testing, please share and subscribe for evidence-based health information.